welcome everyone. In the last 12 months and in the next 10 minutes, I would like to answer you the question, what happens to children after they survive cancer? My vision is to improve survival and quality of life in pediatric oncology, and to do that, my mission is to define and improve long-term socioeconomic effects of childhood cancer and to research new therapeutical modalities. I have two main projects going on, the first about the reintegration to society and the second one about the treatment of neuroblastoma. I would like to start with the comparison of social and economical outcomes between former childhood cancer patients and the general population. Pediatric oncology has improved a lot in recent decades. Now we are at the stage where 1 out of 800 adults is a survivor of childhood cancer. But when a child has cancer, in a way, the whole family and everyone who loves them has it too. Therefore, it is easy to see that pediatric oncology can impact families, marriages, employment, education, and so on. Based on our preliminary researches and previous experiences, we think that former childhood cancer patients have an elevated risk of poor social outcomes. To answer our question, we have conducted a systematic search using the 3 main databases, and during the selection process, we were able to narrow 30,000 articles down to around 300. And now I would like to guide you through the course of life, and with the help of some of our most interesting final results, I would like to show you some of the difficulties and impairments cancer survivors might have to face. So the foundation of an independent living and one of the most crucial points of successful social reintegration is having a job and an income. As you can see, here we have analyzed the employment rates among the childhood cancer survivors and compared them to 3 main subgroups. The first is about articles, when they used population norms as controls. The second subgroup is when they used matched control groups, and the last one is when they used siblings as comparison. You can see that the total odds ratio is under 1, which means that survivors of childhood cancer has a slightly worse chances of being employed. Interestingly, when we compared these survivors to their siblings, this difference was not so slight and it was statistically significant. Okay, if I'm a childhood cancer survivor, I might have a job. Next important question is, how much money do I make? First, I would like to talk a bit more about the subgroups of tumor types in childhood cancer. The cancer types can be divided into hematological malignancies, lymphomas, central nervous system tumors, and solid tumors. Here you can see 3 forest plots based on the comparison they used, and these correlate. So now I would like to talk a bit more about the comparison with siblings, because the differences were the greatest here. So you can see that all subgroups have worse chances of being employed, from which I would like to highlight the survivors of central nervous system tumors who has an odds ratio of 0.24 of being employed. And now about the money. These articles and studies asked their participants about their yearly income, and based on that, they have divided them into low, middle, and high income groups. Here we have investigated the chances of the cancer survivors of being in the low income group. We have found that they have an overall odds ratio of almost 1.7 to earn less compared to their comparisons. Okay, and what's more important than money? It's love. So then we moved on to analyze if the cancer survivors will be ever married. And here we have found that in every subgroup they have a decreased chance. and it was the most emphasized in the hematological malignancy survivors and among the survivors of central nervous system tumors. After marriage comes the child, usually. So then we have analyzed the rates of parenthood among the childhood cancer survivors. I would like to mention here that here the subgroups are, again, as like on the first forest plot, referred to the used control groups. So we also have here a total odds ratio of 0.48, which means that these survivors of childhood cancer have significantly less chance to have children of their own. So to summarize our study, in the main strength, I think, of this study is its complexity, because we are including all types of cancer during childhood, and we are analyzing a vast amount of outcomes. Of course, it has some limitations. For example, that the data is based on questionnaires, and of course, these data can change with time. They can get married or divorced, for example. And I think one of the most important implications for practice is that we must draw the attention of governments and policymakers to address this problem, to find out the key elements that need intervention, and to act accordingly. So to conclude, is that we can and we should establish in pediatric oncological care a disease-specific, nationally and culturally considerate, complex and comprehensive protocol for a lifelong survivorship program. The importance of this task reaches beyond national competencies, therefore this should be performed as a WHO initiative. And the most important task is that we have such a survivorship program is that we must use it. We have, with this project, finished with the data extraction, and we have still some statistical analysis ongoing. We have major groups of outcomes such as education, quality of life, and health risk behaviors, which will be analyzed in the near future. And now I would like to move on to my second project, which is about the treatment of neuroblastoma. Neuroblastoma is the most common extracranial solid tumor in children. And as you can see, the real problem here is the very low rates of survival in the high-risk groups, because the survival of neuroblastoma is greatly dependent on the staging and the grading of the tumor. The high-risk cases account for an amount of every third case of neuroblastoma. There are several therapeutical approaches. Therefore, we would like to compare all of these available therapies in terms of effectiveness and severity and frequency of side effects. And we believe that there is a therapy which is superior compared to the other therapies in the above-mentioned criteria. So I hope you agree that we have come statistically significantly closer to our goals and vision. And I would like to thank you for your attention with a poem from Dylan Thomas, which says, "Do not go gentle into that good night, rage, rage against the dying of the light." Thank you.
Thank you very much for this interesting and thought-awakening presentations. It was really interesting that you compared the later life situation of your previous patient to the siblings and also to the general population. I was wondering whether even the sibling has a problem which grow up in such a family which has such a problem. So if you compare to siblings to the general population, is there any difference between them?
Well, I can answer this question based on the two comparisons when we compared the survivors to the population and to the siblings. And if we hypothesize that they are almost the same or identical groups, then we can say that actually siblings perform better compared to the populational norms in many cases, such as employment and marital rates. So that was actually a quite interesting sign finding of our study, because this can mean that in a way the siblings of these survivors mature more
mature.
Yes, more mature and determined in their life. So it's sad to say, but it has some benefits, and we should see sometimes the possibility.
Really interesting.
I would like to ask, what do you think is behind the fact that less of these patients are able to integrate into work and society? Do you think that there could be lingering health outcomes, or what's your take?
Actually, I have a numerical answer to this, because we have already data about health-related unemployment in these cases, and the odds ratio for that is above 6. So it's really significant compared to the general populations. And we also have another data about job rejection among these patients. And there, if I remember correctly, the odds ratio was 2.42. So these are two numerical data, but of course there's a clinical explanation for that too, because actually cancer itself and the applied therapies have some long-lasting side effects. For example, the chemotherapy can cause ototoxicity, neuropathy, or surgery can have long-lasting side effects or damages, which can influence these.
Thank you.
Did you identify any differences between countries regarding the outcomes? I don't know if it even come up in your mind, but I was wondering if there are countries that maybe manage this thing better. I don't know. I was just wondering.
Yes. Well, we didn't make subgroups based on this, but when a population of studies is really heterogeneous and there are some outliers, we always check that maybe it has something to do with the cultural or regional background. So far we haven't found explanation based on this, rather about age groups and the percentages of different tumors in a study. But I have to mention that most of these studies come from Western countries, USA and European and Northern countries. So we can say that these are some of the most developed countries, and there are no really that big of a difference between them in these terms.
What about these kids' employment? Do they put themselves under pressure, or do they take challenges about the employment, or what are the highest educations, the level of education, what they can get? Or do you have any data, what kind of jobs do they take? Do they go to art parts, or that's all?
Thank you. So these questions are now under the phase of analysis. I can tell you some preliminary results that we are investigating the different levels of education achieved by cancer survivors and their comparisons. And we found that until the end of high school or until college, there's not a really big difference. Only when we use subgroup analysis. For example, historically, the central nervous system tumor survivors perform worse in school. But when we examine the highest level of education, like a master's degree or a PhD, then there's a significant difference between survivors and the comparison groups. And also, we are doing an analysis based on the occupational categories. Unfortunately, it's still under construction, so I cannot tell you more exact data, but we are doing that to see what kind of jobs they are most likely to take.